Well, so great to be back here in person. I mean, this is a huge lift, I know, to put all this together, and we've been waiting for this for quite a while now. I know we've been planning this event. Really appreciate, again, setting this up, take two, but amazing to be back, to really exchange ideas together. And I hope, today and tomorrow can be a conversation, that we can really become more of a think tank and how we can learn from each other. That's really the fun part for us of why we do these. We've always learned something, about these CSF-related disorders and what we're talking about today. I was really so glad to get funding. This is when I was at Stanford to do this project related to quality of life. I'm glad I'm going in front of Errol and Benny because they're hard acts to follow. But these are conversations about metrics we really try to put in place of how we follow Chiari and how we think about quality of life. And that's a very difficult topic. You can sense it and see it across the room, the gestalt of how a patient's doing. This is child or adult. But it's not so easy to put that down in a paper pencil format, in terms of how are they doing now compared to before. And this got quite complicated, in terms of what do we measure, what are the things that are meaningful that we need to track, for this problem. I'm just going to take you through some of these. I know we don't have much time. And what we're talking about here for Chiari. Now, there have been things done, for Chiari before. We always look at symptoms, and these are registries that have been done. It's hard to read this, but there is a host of things, right, that could be associated with Chiari. We don't know how causal they are. It's challenging to put all this together, but all these are related to neurologic manifestations that we can test in the clinic. And these are more objective, a lot of these things, and this is easier to track. If we do big data approaches, we can look for these things in our notes, and double vision, things that are really clear that we could follow, and is that better or worse, or things like that. This is where it gets harder to think about neurocognitive symptoms, psychological concerns. And of course that we know in other diseases affects tremendously how you're doing, how you rate your pain scores. We know this from, I've been studying this with PTSD in the military research consortiums with the Department of Defense for a long time, of how that affects headache severity scales and things like that. Your psychological health plays such a big role. And this is where it gets more dirty, right? Look at all these different cognitive areas: memory, depression, anxiety, bipolar disorder. Now, these aren't, we think, again, causal, but there are higher associations clearly in this population. And that is what intrigued me in terms of very similar to our concussion population that many of us manage here on the pediatric side. They're really difficult to figure out how these symptoms might relate. So why do we get cognitive deficits with Chiari? How does that occur? This is an area in the back of the cerebellum. How do you account for something in the frontal lobe? And this is where you have to know your neuroanatomy, in terms of the amount of connections that exist, between the cerebellum and the deep part of the brain, as well as the cortex. And we know those areas are very important in anxiety and depression, chronic pain. What does surgery do for these? Why does surgery in the back there affect some of these potential pathways and signals? And then does it matter if you're a child or an adult? Is it the same disease? We wrestle with that a lot. So this has been looked at with Mark Luciano's group. He did really great studies to look at cognitive effects and looking at really clear areas of working memory. And again, the same thing came up. Well, is this from compression? Is this a non-specific effect with Chiari that somehow relates to chronic pain? We don't have proof of any of these things, which make it really tough to figure out, how do we measure that? How do we put objective criteria for what we're doing? We do imaging. We have exquisite imaging we could do to follow pathways, and called the connectome, which is your white matter bundles in the brain, and we can see changes in the white matter. from things that we do. Is that relevant in Chiari? We're still, I think the answer is still out. And we're not really quite sure, but there are clear changes that we can see that correlate with neurocognitive function, which I think is really interesting. And these are not just in the cerebellum. These are, also in deeper parts of the brain. So I'm just going to keep going here. And we can look at who is decompressed versus non-decompressed, and how does that compare? And, it's with or without here's a pointer, sorry. Here we go. So these are controls in terms of looking at neuropsychological function. Higher score, the better. Chiari is sort of down here. These are different areas of memory and processing speed, and you can see it's quite dirty, and surgery doesn't really bump them up to normal. So what is going on again in this population? It doesn't just reverse some of these problems. A lot of work in this registry project looking at attention, pain, and delayed recall and how that affects function. So I'm just going, because I know the time is important here. Cognitive domains, there's this cerebellar cognitive affective syndrome. It's something that we've coined, many of us in this field, that looks at a lot of these different areas that we know is affected by cerebellar function. And this is not specific to Chiari. Patients with brain tumors, say, in the cerebellum, we've talked about this cognitive affective syndrome. So this is something now we at least have on the table to talk about. I would say even 5 years ago, it's not something we really recognize as something that we understood enough to put it into a syndrome. And, Chiari then is getting more complicated, right? In terms of it's a diagnosis, radiologic imaging finding that then leads to some intervention or follow-up. But as you put it part of a syndrome, it becomes a lot more, I think, holistic to think about what is a patient going through with certain findings. And the cerebellum, we used to call the little brain, unbelievable amount of neurons in the cerebellum. That tiny structure, is almost half the neurons in the human brain, in the cerebellum. So of course it has a huge role to play. People always bring up, what is the function of the cerebellar tonsil itself, which is where we're operating, right? That's what's compressed. But the syndrome is way beyond the cerebellar tonsil. And this is where that disconnect becomes really difficult to understand. And if you unfold the cerebellum, it's about the same surface area as one, cerebral hemisphere, half the brain. So this is a lot in a very small part of the brain. And this is all the connections and different areas that we could subdivide in the cerebellum from this neuron paper not too long ago. So we went through this with the ASAP, it's kindly to fund this work through the research committee, and we looked at quality of life measures. We had cohorts, about 180 patients. These are largely kids. I have done mostly kids versus adult at Stanford. And many of them were decompressed, but not all, and we followed them very carefully. We used domains that our pain clinic used, and they were embedded with me in my clinic in the same room. So I got to hear all their chatter and how they follow these patients. And they go through these iPad surveys. They will not see the patient until they've completed this whole iPad profile of everything they're going through. And they've done a lot of work to look at the child versus the parent as well. So actually both fill them out. And a child that's old enough, that they use age 8 or above, or, kids are getting more and more sophisticated. So maybe 6, but you can decide what age is reasonable. But it's very interesting to see the differences, child versus parent, and how that association is linked or not linked. So that was really interesting. And I learned all this from the pain team of how they apply it, and it's really quite clever, I think, and we have a lot to learn from them. They're used to this space. They're used to understanding chronic symptoms and how that affects quality of life. And we're not so good about that as surgeons, right? We go in and out, but we don't really quite have that continuity over years. The pain scores were fascinating. If you just look at where patients with Chiari have pain. Now, you'd expect a lot in the back of the head and the neck, and there's definite improvement after surgery from before. Darker means much higher pain thresholds, but it doesn't just go away. But there's other areas of pain throughout the body, right, that we don't really focus on in our notes. And do we even ask about those things? Not usually, right? It's a very limited visit, focusing on head and neck. We should think a little bit more beyond the head and the neck. These PROMIS scores are what the pain team uses. There are many measures that look at fatigue, say, and the fatigue is related to your symptoms day to day and what you're going through. Just to get through the day, there's so much stamina, so much you have to deal with, and it's a distraction when you have chronic symptoms. So that fatigue is something that the pain team measures quite a bit, and this is pre-op and post-op, and you can see never the more blue means you're doing better, and there's more blue afterward, but you sure would love to see a lot more blue, right? These kids are better, but they're not fine, like everything's back to normal. There are ongoing challenges that they face that we have to keep in mind when you start thinking about all the different areas that could affect their quality of life as a child. This is interesting, looking at the child versus parent. You'd like to see a straight line here where the kid will report something and the parent will report it, and they'll meet up in the same spot. And you like to see this nice slope going up. And you can see it's a little bit out of the slope. Some parents over-report what the child would say, and some under-report. So you have to think about that. And I think that discontinuity is interesting to learn about every family and child before surgery, because this is about setting expectations. And it's setting expectations for the child as well as the parent in terms of what they're going through. And if they don't quite agree up front, that means the kid is either not reporting or it's the opposite. And we need to just put that into context. I think this has been a really important finding of how we relate some of these scores, and the outliers are the ones we focused on quite a bit. And there might be some that we need to manage prior to surgical intervention. And in the adult side, we do this a lot more. Let's get some help for the anxiety or depression prior to surgical intervention. Things will not go well with our surgery if we don't get them back into a better psychological health state. It will backfire. The surgery will put them over the edge, and it'll be much more difficult to manage some of the comorbidity symptoms. So we have to keep that in mind. So I know I'm out of time, but the cerebellum is not so small after all. We need to really think about all the implications of where we are. Although we are talking about a very discrete part of the brain, Syringomyelia we didn't even cover here, and some of the relationships we found with this research work we're doing, that presence of syrinx, presence of scoliosis, all these are negative predictors of outcome, meaning you're not going to do as well with some of these other quality of life scores with scoliosis, for example. Why is that? We can talk about that over the day, but there are things that we pay attention to now. Age, certain things are higher risk factors for not returning back to baseline, and that's where we need to focus on that group of patients to figure out how to help them more and what's going on that's preventing them from getting better. And that's a talk that we can have a little bit later after lunch. So we need to track this very carefully. The more we can do in this domain to look at these scores and really figure out what we're doing. What I didn't show you is there are other outcome scales that we already use. Chicago outcome scores, Chiari, there's others. Did they correlate with all the stuff we're gathering? No. Well, that's not going to give you much hope that there's a discordance of all these outcome measures right now for Chiari. We still have not really developed scales and measures that are reliable and valid that we think will match someone's quality of life and something we really can track. So we tracked so many things with this half-hour survey, but there were clearly subsets of those that we need to use that were very, very important. And those are the ones we need to target, because there's fatigue in surveys, right? Patients don't like to fill all these things out. It's cumbersome. And and the pain clinic mandates it before the clinic, which is great, but harder for us to manage that, right, in the surgical side often. So in honor of Jimmy V, and I don't know if you saw the ESPYs last night, Dick Vitale's award, you know, don't give up here. Let's keep pushing and keep learning together. We need your input to figure out how this affects you and how we can work together to uncover some of these areas that we need to get all on the same page in terms of tracking over time. And I really thank the ASAP team for funding this work. The work that we did got integrated into our EPIC, which is our electronic medical record, which made it so seamless to follow these patients before and after. It was so much nicer to integrate that into the medical visit, so it's not an outlier research thing. That's what the research team through ASAP helped us do there, and it really has paid off. And at Duke now, I'm doing the same thing and on that same model to build these relationships into your electronic medical record. So I really appreciate you listening, and we can talk if there's any questions later. So thanks for your attention.